We are now starting our lecture on trochanteric hip fractures, a condition that represents almost half of all proximal femur fractures and has major impact on elderly patients. These fractures are strongly associated with loss of independence, longer hospitalization, and high mortality rates. For exams, always remember that the one-year mortality following a hip fracture is typically between 20 and 25%. This is a key fact that often appears in questions. Trochanteric fractures are extracapsular injuries. They occur outside the hip joint capsule and are located from the intertrochanteric line down to about 5 centimeters distal to the lesser trochanter. This region can be further divided into trochanteric and subtrochanteric zones, as illustrated in the first schematic figure. Notice how the diagram clearly separates the intracapsular area, which is proximal and medial, from the extracapsular zones, which include the trochanteric and subtrochanteric regions. That anatomical distinction is not only important for classification, but also for treatment planning, because blood supply and healing potential are very different between intracapsular and extracapsular fractures. Now let's move to the radiographic images. In image A, you can see a severely comminuted trochanteric fracture with loss of lateral support. Pay close attention here. The lateral wall is one of the most critical structures in trochanteric fracture classification. If it is intact, the fracture is usually stable. If it is broken, even a simple pattern becomes unstable. This is a classic exam point. Image B demonstrates medialization of the femur. This means that the shaft has shifted medially relative to the head and neck fragment, an indication of instability. And finally, image C shows a displaced transverse fracture seen under fluoroscopy. These examples emphasize how radiographs guide us in identifying fracture morphology and stability, which directly influences treatment choice. Another important reminder is that not all fractures in this region are purely traumatic. Sometimes they can be pathological fractures caused by primary or secondary bone tumors, by bone cysts, or by metabolic diseases such as Paget's disease. The presence of lytic or abnormal bone texture on the radiograph should raise suspicion for these conditions. For exams, be prepared for a question asking you to recognize that a seemingly simple fracture line may actually represent an underlying pathological process. We now turn to classification systems, which are central both for clinical practice and for exam preparation. Historically, many systems have been proposed. Boyd and Evans described one in 1949, and Mueller introduced the AO system in 1990. However, the most widely used and tested today is the OTA-AO's classification, which is practical, reproducible, and internationally accepted. The OTA-AO system divides trochanteric fractures into three main types: A1, A2, and A3. These are shown clearly in the colored schematic illustrations. Type A1 is the simplest. It is a two-part fracture with an intact lateral wall. Because of this preservation, it is considered stable. Look carefully at the drawing. You see just one fracture line with two large fragments. Clinically, these fractures are relatively easy to fix, with lower risk of collapse. For exams, remember the phrase, A1 with intact lateral wall is stable. Type A2 is more complex. It is a multifragmentary fracture with comminution and loss of the lateral wall. The drawing shows multiple pieces, especially involving the posteromedial cortex. These fractures are unstable and have a much higher risk of collapse after fixation. It is very important to recognize A2 in radiographs because the loss of buttress support means we cannot rely on simple fixation. We must plan for stronger implants or augmented fixation. Exam questions frequently contrast A1 and A2 by asking about the role of the lateral wall. And finally, A3 is the most unstable variant. It includes reverse oblique or transverse fractures, where the fracture line runs across or upward starting near the lesser trochanter and extending laterally. In these patterns, the lateral wall is completely ineffective, and the fracture tends to medialize under weight bearing. The illustration highlights how the shaft is detached from the trochanteric region. For exams, remember the key phrase, reverse oblique fractures behave worse than comminuted patterns because they lack cortical support. Recognition of A3 is essential since they often require intramedullary fixation rather than a simple plate. To summarize this classification, always think in three steps: A1 stable, A2 unstable due to comminution and loss of the lateral wall, and A3 unstable due to an unfavorable fracture line such as reverse oblique. If you can remember this simple progression, you will avoid one of the most common mistakes in exams, which is misclassifying stability based on only the number of fragments. The real determinant is the integrity of the lateral wall and the direction of the fracture line.
Now that we have established the classification of trochanteric fractures, let's move into the etiology. In elderly patients, these fractures most commonly result from low-energy falls, often from standing height or even simply falling out of bed or from a chair. What is critical here is the biomechanics of the fall. Because of reduced coordination and protective reflexes, older adults tend to fall sideways, directly impacting the hip. Unlike younger patients who may extend their arms to protect themselves, elderly individuals frequently lack that protective response, which makes the hip the primary point of contact. This mechanism is one of the reasons trochanteric fractures are so prevalent in the geriatric population. Several contributing factors increase the risk of falling. Table 54.1 provides an excellent summary. Let's walk through it carefully because this is an important list for exams. Increased age is obvious, but note also the role of concurrent medical illnesses, mental impairment, and disorders of gait and balance. Physical disability and lack of regular exercise weaken protective mechanisms. Greater dependence on others, malnutrition, and undernourishment also contribute. Postural imbalance, previous strokes, visual abnormalities, and tranquilizer or alcohol use are strong risk factors. Finally, multiple medications, especially hypertensives, further impair stability. For exams, always remember, falls in the elderly are multifactorial. It is not just about osteoporosis, but a combination of vision, balance, cognition, and polypharmacy. This brings us to the concept of frailty. Frailty is best understood as a clinical syndrome characterized by reduced physiologic reserve and diminished resistance to stressors. In practice, it often manifests as sarcopenia, loss of muscle mass and strength, which directly leads to impaired balance and mobility. Frailty and sarcopenia are intimately connected with falls, and their recognition is crucial not only in clinical care, but also in exam scenarios. Moving on, let's discuss associated injuries. In about 4% of cases, trochanteric fractures occur alongside other fractures. The most common associated injuries are fractures of the ipsilateral distal radius or proximal humerus. Less commonly, we may encounter pubic rami fractures or other pelvic injuries. And one very important exam point, in up to 21% of low-energy fracture patients, head trauma severe enough to justify a CT scan is present. So, in any exam question describing an elderly patient with a hip fracture after a fall, always consider whether additional injuries, especially cranial trauma, needs to be investigated. Now let's turn to the diagnosis. Clinically, the patient presents with acute pain around the hip and thigh, usually with inability to stand or walk. Pain can radiate to the ipsilateral knee. This is a classical misleading feature, and exams often test it. Hip fractures can present as knee pain. On inspection, bruising and swelling may be evident. On palpation, hematoma is common. The affected leg is often shortened and externally rotated, but remember that in some incomplete or non-displaced fractures, the only finding may be localized pain on compression. Radiographic evaluation is fundamental. The standard includes an anteroposterior pelvic X-ray and a lateral hip X-ray. Both hips should be imaged for comparison. The AP pelvis helps determine varus alignment, reduction quality, and sometimes reveals associated pelvic fractures. The lateral view shows displacement or angulation, which is crucial for surgical planning. However, not all fractures are visible on plain radiographs. Figure 54.4 illustrates this. It shows an incomplete trochanteric fracture visible only on MRI, marked by an arrow. CT or MRI is especially useful when the fracture is suspected clinically, but radiographs appear normal. For exams, remember the phrase, if plain X-rays are negative but suspicion remains high, MRI is the most sensitive test. This is a frequent exam trap, contrasting X-ray, CT, and MRI in terms of diagnostic yield. Now let's discuss the pathoanatomy of trochanteric fractures. The proximal femur is unique because it contains both cancellous and cortical bone, making it strong yet vulnerable depending on the direction of the applied forces. A critical region here is Ward's triangle, shown in figure 54.5. Ward's triangle is an area of relative weakness between bundles of trabeculae. It is often the site where unstable fractures propagate. Another essential structure is the calcar femorale, sometimes called Adam's arch. This dense cortical bone runs posterior medially, providing key support against collapse. For exams, you must remember damage to the calcar is associated with instability and poor prognosis. Questions often test your ability to identify which structures provide medial buttress support in hip fractures, and the calcar is the correct answer. The figure clearly illustrates these trabecular patterns. Notice how the compressive trabeculae ascend medially, forming strong reinforcement, while the tensile trabeculae cross laterally. Between these lies Ward's triangle, the radiolucent zone where bone is weakest. Understanding this trabecular architecture explains why some fractures collapse into varus and why others medialize. Finally, let's mention isolated fractures of the trochanters. A fracture of the greater trochanter may result from avulsion of the gluteus medius and minimus. This sometimes presents with Trendelenburg gait, since abductor strength is compromised. In rare cases, the fracture line may extend into the intertrochanteric region, making it more unstable. Isolated fractures of the lesser trochanter, particularly in adults, are suspicious for pathological causes, often metastases. For exams, this is a red flag. An isolated lesser trochanter fracture in an adult should always be considered pathological until proven otherwise.
When discussing treatment options for trochanteric hip fractures, the first distinction we must make is between non-operative and operative management. In modern practice, the overwhelming majority of these fractures are treated surgically. However, there remains a very small subgroup of patients in whom non-operative treatment is considered. These are usually frail, elderly patients over the age of 75, often bedridden or with very poor functional reserve. In this group, the risks of surgery may outweigh the potential benefits. The prognosis in these cases is unfortunately poor, with mortality rates within 30 days reaching alarming levels when managed without surgery. For this reason, realistic goal setting is essential, involving both the patient and the family in discussions that sometimes extend into end-of-life care planning. Analgesic nerve blocks may be used to provide comfort since immobilization or traction is often difficult to maintain in such fragile patients. For exams, remember this key point. Non-operative treatment is the exception, reserved only for highly frail, non-ambulatory patients with poor life expectancy. Now, let's turn to the operative treatment, which is the standard of care. Before surgery, preoperative planning is critical. This includes assessing comorbidities, such as anemia, coagulation disorders, electrolyte imbalances, and hypovolemia. Other common issues like diabetes, heart failure, pneumonia, and COPD exacerbations must be stabilized as best as possible before surgery. A striking statistic to remember: blood loss from a trochanteric fracture is often between 500 and 1,000 milliliters, and many patients are hypovolemic upon admission. This is why fluid resuscitation and close monitoring are essential. Another important exam topic is thromboprophylaxis. The current consensus is that low molecular weight heparin remains the standard, though aspirin has also been studied. The key principle is that anticoagulation should begin as early as possible, but must be individualized to balance bleeding risks. Questions often test knowledge about timing. Pharmacologic prophylaxis should continue for at least 28 days after surgery. Equally important is the timing of surgery. Delays beyond 24 to 48 hours are associated with increased mortality and complications. For exams, a critical key phrase is, hip fracture surgery should be performed as soon as the patient is optimized, ideally within 24 hours. This is a frequent question. Now let's turn to the imaging figures provided. In figure 5411A, you can appreciate a reverse fracture mine leading to medial displacement of the femoral shaft. This is a classic example of an A3 fracture pattern, which, as we discussed earlier, is biomechanically unstable.
In figure 5411b, fixation has been performed with an intramedullary nail. Notice how the proximal part of the nail abuts against the superior femoral neck to resist medialization. Still, some degree of medialization has occurred, which is a known complication even after proper fixation. For exams, always remember, intramedullary nails are biomechanically superior for unstable patterns like reverse oblique fractures, but medialization can still occur. The earlier figures also add valuable insights. Figure 54.6 demonstrates how aging alters the morphology of the femur. The cortical bone becomes thinner while the medullary cavity expands. This explains why older bone is weaker, more prone to fracture, and collapses more easily. Figure 54.7 shows the anatomy of the hip capsule and ligaments, the iliofemoral ligament anteriorly, the pubofemoral and ischiofemoral posteriorly. This Y-shaped configuration, sometimes called the ligament of Bigelow, is essential for stability. Exams may test your knowledge of which ligaments resist which movements of the hip. In figure 54.8, we see a fracture of the greater trochanter. This might be isolated or extend into the intertrochanteric region. Isolated greater trochanteric fractures may sometimes be managed conservatively if non-displaced, but careful imaging is necessary, often with CT or MRI, because the fracture line may extend further than plain radiographs suggest. In contrast, figure 54.9 illustrates an isolated fracture of the lesser trochanter. In adults, this is highly suspicious for a pathologic process, such as metastasis. The case presented here shows deposits from a lung tumor. For exams, this is a red flag. An isolated lesser trochanteric fracture in an adult is considered pathologic until proven otherwise. Finally, figure 54.10 demonstrates a trochanteric hip fracture treated conservatively without traction, healing in a valgus position. Clinically, this results in limb shortening and gait disturbance. This reinforces the point that conservative treatment of these fractures is rarely satisfactory and should be avoided except in very select cases. To summarize this section, surgical stabilization remains the gold standard. Preoperative optimization, timely surgery, appropriate implant selection, and careful postoperative care all directly influence outcomes. Exam questions will frequently test when non-operative treatment is appropriate, what the timing of surgery should be, which implant is best for unstable fractures, and what the expected complications are when these principles are not followed.
One of the most important challenges in treating trochanteric hip fractures, especially the unstable A3 patterns, is the loss of lateral wall support. Without that buttress, the femur tends to medialize, pulled by the adductors. This medialization leads to several consequences: reduced bone-on-bone contact, delayed healing, higher risk of nonunion, and loss of femoral offset, which translates into impaired function and gait abnormalities. Clinically, patients with significant medialization often complain of pain and weakness, and radiographically, this complication is a red flag for fixation failure. Figures 54-12 and 54-13 highlight this concept. In figure 54-12, you can see a transverse A3 fracture treated with a sliding hip screw where excessive sliding has occurred. The lag screw has migrated, leading to about 75% medialization, far beyond acceptable limits. This example demonstrates why cephalomedullary nails are now the preferred implant for unstable fractures because they reduce the risk of excessive sliding and medialization. Figure 54-13 shows how medialization is measured, the ratio A/B multiplied by 100. For exams, remember, medialization greater than 50% is associated with worse functional outcomes. A medialization of more than 5 millimeters has been correlated with increased postoperative pain. Now, let's explore the different implant options. Broadly, implants can be divided into extramedullary devices and intramedullary devices. Extramedullary fixation refers to plates and screws applied to the lateral side of the femur, with the sliding hip screw being the most common. Intramedullary fixation refers to cephalomedullary nails, which pass through the medullary canal. The choice between these two has been the subject of countless studies, but the general consensus is clear. Sliding hip screws remain appropriate for stable A1 fractures with intact lateral wall, while cephalomedullary nails are preferred for unstable A2 and A3 fractures. Let's look at the figures to illustrate this concept. Figure 54-14 shows an outdated implant, a fixed nail plate that is penetrated into the hip joint as the fracture collapsed. These older devices, such as Jewett or McLaughlin plates, are no longer recommended because they fail to allow controlled collapse at the fracture site and instead lead to catastrophic penetration into the joint. In contrast, figure 54-15 demonstrates proper use of a sliding hip screw in a stable A1 fracture. Notice how the screw is well centered in the femoral head and supported by the intact lateral wall. This is the textbook example of correct indication and placement. However, modifications of the sliding hip screw have been developed to extend its use into unstable patterns. One such modification is the lateral trochanteric stabilizing plate, illustrated in figure 54-16. Here, an additional plate supports the lateral wall, resisting medialization. While this technique has value, cephalomedullary nails are still generally preferred for unstable fractures. Another interesting device is the Medoff plate, seen in figure 54-17. This design incorporates two interdigitating femoral plates, allowing sliding along the longitudinal axis of the femur. In the case shown, a reverse A3 fracture has healed in good alignment with minimal medialization. Although its use is not widespread, the Medoff plate remains an effective option, particularly where intramedullary nails are not available. For exams, just remember, the Medoff plate is a sliding variant that can handle reverse oblique fractures better than standard sliding hip screws. Other extramedullary options include the 95-degree condylar blade plate and the proximal femoral locking plate, shown in figures 54-18 and 54-19. Both of these provide rigid static fixation, which is problematic because they do not allow controlled collapse at the fracture site. As a result, they carry high failure rates and are not recommended for routine use. The locking plate may have a role in special situations, such as periprosthetic fractures or when anatomical reconstruction is required in younger patients, but not for standard trochanteric fractures. To summarize this section, the guiding principle is sliding hip screws are excellent for stable A1 fractures with intact lateral wall. Cephalomedullary nails are superior for unstable A2 and A3 fractures, minimizing medialization and reducing failure. Trochanteric stabilizing plates or Medoff plates may still have niche roles, especially when nails are not feasible. Blade plates and locking plates are largely obsolete for routine trochanteric fractures due to high failure rates.
The introduction of the gamma nail in the 1980s marked a turning point in the management of trochanteric fractures. Since then, many cephalomedullary nail designs have been developed, varying in length, diameter, and locking mechanisms. The goal of these nails is to provide stronger biomechanical stability than sliding hip screws, especially for unstable A2 and A3 fracture patterns. However, despite their advantages, cephalomedullary nails are not free of complications. Early designs suffered from issues such as fracture at the tip of the nail, implant breakage, or extrusion of the proximal fixation. Newer models have addressed many of these problems, but their use still demands careful surgical technique. Multiple randomized trials have compared sliding hip screws to cephalomedullary nails. The overall evidence suggests that while the complication rate may be slightly higher with nails, functional outcomes are largely equivalent. However, one crucial difference consistently emerges. In unstable fractures, nails perform better, reducing collapse and medialization. Registry data confirm this, showing lower reoperation rates for unstable fractures treated with nails compared to screws. For exams, this is a key phrase. Sliding hip screws and nails are equivalent for stable A1 fractures, but cephalomedullary nails are superior for unstable A2 and A3 fractures. Figures 54-20 illustrate the diversity of cephalomedullary nails. Panel A shows a gamma nail, Panel B a trigon nail, Panel C a targon nail, and Panel D a long trochanteric femoral nail. Despite differences in design, the principle remains the same. Intramedullary placement provides a load-sharing construct that resists varus collapse and medialization. Nail length is another exam-relevant detail. All manufacturers produce both short and long nails. In trochanteric fractures, the short nail is generally sufficient, provided the fracture line does not extend more than 3 centimeters below the lesser trochanter. For fractures extending further distally, a long nail is required. For exams, remember this cutoff. Short nails for typical trochanteric fractures, long nails for subtrochanteric extension. Dynamic versus static distal locking is another important concept. Static locking creates a rigid construct, while dynamic locking allows controlled compression during weight bearing. Evidence suggests that dynamic locking may provide superior outcomes in unstable fractures, though results vary. Moving on to external fixation, this is not a standard technique for trochanteric fractures, but may be used in exceptional cases, particularly where rapid, minimally invasive stabilization is needed. Figure 54-21 shows an example of an external fixator applied with pins proximal and distal to the fracture. The advantages include minimal blood loss, reduced operative time, and the possibility of using local anesthesia. However, disadvantages such as pin tract infection and patient discomfort limit its widespread use. For exams, remember, external fixation is a salvage or temporizing procedure, not a definitive solution. Now, let's briefly discuss arthroplasty. Total hip replacement is rarely indicated for pure trochanteric fractures because of the instability of the fracture complex. But in elderly patients with poor bone stock, or when trochanteric fracture coexists with advanced arthritis, arthroplasty may be considered. Still, the gold standard remains osteosynthesis with either screws or nails. Finally, let's address the choice of implant according to guidelines. The American Academy of Orthopedic Surgeons, AAOS, recommends sliding hip screws or cephalomedullary nails for stable intertrochanteric fractures, and cephalomedullary nails specifically for unstable A2 and A3 fractures. The UK NICE guidelines echo this, emphasizing cephalomedullary nails for reverse oblique and subtrochanteric extensions. Large registry studies from Norway and the United States further support these recommendations, showing lower reoperation rates and better functional scores with nails in unstable patterns. In summary, when choosing an implant, base your decision on fracture stability. For stable A1 fractures, sliding hip screws are sufficient. For unstable A2 and A3 patterns, cephalomedullary nails are the implant of choice. External fixation remains a backup option, and arthroplasty is rare but possible in selected elderly patients with joint disease. For exams, this decision-making flow is often tested. Recognize the fracture pattern, identify stability, and match it to the appropriate implant.
The first step is preoperative planning. A checklist approach is always emphasized. The patient must be placed on a fracture table, the injured leg in traction, and the uninjured leg either flexed out of the way or positioned in the scissor position. Positioning must be secure, and fluoroscopy should be aligned between the patient's legs to provide high-quality images. Having the right equipment is critical. Reduction aids, clamps, probes, and appropriate implants must all be available before starting. For exams, remember, poor planning is one of the most common causes of intraoperative complications. Patient positioning is well illustrated in Figure 54-22. The patient is supine, with the injured leg fixed in a traction boot and the uninjured leg flexed in a stirrup. Lateral support and a groin post stabilize the pelvis. This setup allows the surgeon to apply controlled longitudinal traction and, if needed, internal rotation. For obese patients or those with high-energy injuries, fracture displacement can be severe, and achieving reduction may require significant traction or even skeletal traction before the procedure. The next critical step is fracture reduction. The goal is to achieve anatomic or slight valgus alignment. On the AP radiograph, a slight valgus position is ideal as it minimizes the risk of cutout and reduces limb shortening. Figure 54-23A demonstrates a varus malreduction, which must never be accepted as it predisposes to fixation failure. Figure 54-23B shows a proper valgus reduction, with a small medial opening that is acceptable and even protective against collapse. On the lateral radiograph, reduction must ensure that the head, neck, trochanteric region, and shaft align in a straight line, as shown in Figure 54-25. Any anterior or posterior translation must be corrected, otherwise excessive collapse or delayed healing may result. Figure 54-24 illustrates an inadequate reduction, where the lag screw was forced into a superior position in the femoral head due to varus malreduction, inevitably leading to cutout. This is a classic exam image. Several techniques can help achieve and maintain reduction.
Posterior sag, for example, can be corrected with a posterior reduction device, as seen in figure 5426. This device applies upward pressure at the fracture site, lifting the femoral shaft into proper alignment. Alternatively, a bone lever or reduction clamp may be used to elevate the femur. In more complex cases, especially A3 reverse oblique fractures, cerclage wires may be applied to maintain reduction. Once reduction is achieved, the positioning of the guide wire becomes the next decisive step. Proper reduction is a prerequisite for correct wire placement. If the fracture is left in varus, the guide wire will inevitably be placed too superiorly, resulting in an unacceptable position. Radiographic parameters guide this step. The Garden Alignment Index, figure 5427, provides a useful reference. 160 degrees on the AP and 180 degrees on the lateral are normal. Acceptable reduction allows a range of 170 on the AP and 160 to 175 on the lateral, but varus or excessive angulation is never acceptable. Now let's emphasize the most exam-relevant measurement, the tip to apex distance, TAD. This is shown in figure 5429. It measures the distance from the tip of the lag screw to the apex of the femoral head, corrected for magnification. The ideal TAD is 25 millimeters or less. Values above this threshold are strongly associated with lag screw cutout. For exams, this is a must-know fact. TAD less than 25 millimeters minimizes the risk of failure. Other methods of assessing screw position include dividing the femoral head into 9 zones, as seen in figure 5430. The ideal position is central on the lateral and inferior central on the AP. Peripheral placement should never be accepted. Another practical rule is the calcar reference TAD, which emphasizes the importance of placing the screw close to the calcar for maximum biomechanical support. To summarize this section, always achieve anatomic or slight valgus alignment. Avoid varus at all costs. It is the most common cause of cutout. Posterior sag must be corrected before fixation. Guide wire and lag screw must be placed centrally on the lateral, inferior central on the AP. Tip to apex distance must be less than 25 millimeters. These principles are tested again and again in exams, often with X-ray images of inadequate reduction or misplaced screws. Recognizing these mistakes and knowing how to correct them is just as important as performing the operation itself.
Now we move to a very practical and exam-relevant aspect of trochanteric fracture fixation, the design and technical details of the lag screw. The lag screw is essentially a large cancellous screw. Over the years, many alternative designs have been developed, including pins, bolts, tri-flanges, extendable wings, and helical blades. Biomechanical studies often suggest advantages of one design over another, but clinical studies have shown that both the traditional cancellous screw and newer options, such as the helical blade, perform equally well. For exams, remember this key point. There is no single superior design universally accepted, but understanding the principles of screw placement is critical. Other innovations include cement augmentation of the lag screw. In this technique, bone cement is inserted around the screw to increase purchase in osteoporotic bone. However, results are mixed. While some studies show that cement can help in severely osteoporotic patients, others report higher complication rates, such as nonunion or avascular necrosis. So, for exam purposes, think of cement augmentation as an option reserved for selected high-risk cases rather than routine practice. Now let us analyze the radiographic images. In figure 5428, we see the correct reduction and fixation of an A1 trochanteric fracture. In part A, the preoperative film shows the fracture. In part B, the lag screw is positioned low and central on the AP view. This is important. A low central position gives better biomechanical stability and reduces the risk of cutout. You can also notice that the fracture has been distracted slightly into valgus, opening medially. With weight bearing, medial bone contact will be restored and the fracture will consolidate with minimal limb shortening. Finally, in part C, the axial view confirms that the fracture is reduced anatomically, with the screw placed centrally. For exams, always remember, low central on AP, central on lateral. Peripheral placement must be avoided. Moving to the next illustration,
Figure 5429, introduces the concept of the tip to apex distance, or TAD. This is one of the most important numerical values in the fixation of trochanteric fractures and is frequently tested in exams. The TAD is the sum of the distances from the tip of the lag screw to the apex of the femoral head measured on both the AP and the lateral radiographs corrected for magnification. The magic number here is 25 millimeters. If the TAD is 25 millimeters or less, the risk of screw cutout is very low. If it is greater than 25 millimeters, the risk increases dramatically. So, for exams, memorize this. TAD less than 25 is safe. More than 25 is unsafe. Another method of assessing screw position is shown in Figure 5430. Here, the femoral head is divided into zones and the ratio method is used. The screw position is measured relative to the head, and an ideal location is low central on AP and central on lateral. This again emphasizes that peripheral positions are unacceptable because they lead to cutout. Now let us discuss the surgical technique of inserting a sliding hip screw. The key surgical steps are summarized in the checklist. First, the patient is placed supine on the fracture table, and reduction is confirmed with fluoroscopy. A lateral incision is made over the greater trochanter, and the vastus lateralis is either split or reflected anteriorly. The guide wire is inserted under fluoroscopic control, and its position determines the final location of the lag screw. After drilling, the lag screw is inserted, typically 5 to 7 millimeters short of the subchondral bone. The plate is then applied to the femur and secured with cortical screws. Closure follows in layers, and the patient is mobilized as soon as possible. On the cross-sectional anatomical illustration, you can see the surgical approach through the vastus lateralis. The muscle is retracted anteriorly, giving access to the lateral femur. This highlights the importance of respecting the anatomy and minimizing soft tissue trauma. Another important exam concept is shown in Figure 5432. This demonstrates what happens if the lag screw is placed peripherally. On both the AP and the lateral images, the screw may appear to be inside the bone, but in reality it can penetrate the joint. This complication must be avoided by ensuring correct central positioning and by carefully checking fluoroscopic views. Finally, regarding implant length, most plates have barrels of around 38 millimeters. If the screw length is 80 millimeters or less, a shorter barrel plate should be used to prevent the screw from jamming. If the screw is longer, a 4-hole plate is usually sufficient. The compression screw may be added to assist sliding and collapse at the fracture site. In summary, the critical points to take away from this section are: always aim for anatomical or slight valgus reduction. Place the lag screw low central on the AP and central on the lateral. Keep the tip to apex distance under 25 millimeters and avoid peripheral or superior positions at all costs. These are high-yield exam questions and essential surgical principles for safe fixation of trochanteric fractures.
In this section, we will focus on the surgical technique of cephalomedullary nail fixation for trochanteric hip fractures and the most important complications associated with this treatment. We will also cover post-operative care, outcome expectations, and future perspectives in the management of these fractures. Cephalomedullary nail fixation surgical technique. The procedure begins with the patient placed supine on the fracture table, with the legs scissored, the torso shifted slightly away from the site of the fracture, and the ipsilateral arms supported above the chest. Traction is applied to aid in reduction, and the quality of alignment is checked with the image intensifier in both AP and lateral views. A 3 cm lateral incision is made just proximal to the greater trochanter. The fascia lata is incised and the musculature is split to expose the tip of the greater trochanter. At this point, a guide pin is inserted into the proximal femur and its correct position is confirmed under fluoroscopy. The pin should be placed slightly posterior on the AP view and centered on the lateral view, ensuring proper trajectory into the femoral head. Once the guide pin is satisfactory, the proximal femur is reamed and the intramedullary nail is inserted. The surgeon then uses the guide to determine the appropriate length of the lag screw.
The screw is introduced 5 to 7 millimeters from the subchondral bone, again checking that the final position is low and center on the AP view and center on the lateral view. This step is crucial because an incorrect position will predispose the implant to cutout or varus collapse. A distal locking screw is then inserted, securing the construct. The wound is closed in layers with absorbable sutures for fascia and subcutaneous tissues. A sterile dressing is applied, and the patient is transferred to a bed with a pressure-relieving mattress. Radiographic figures. Figure 5433 shows a case of varus collapse in which the cephalomedullary nail failed due to an incorrect screw position. Instead of sliding dynamically, the lag screw acted as a fixed implant, leading to loss of fixation. This highlights why correct reduction and positioning are essential to avoid difficult revision surgeries. Figure 5434 demonstrates the correct placement of the guide pin into the greater trochanter. Positioning the entry point too anterior or too lateral can result in malalignment of the entire construct. Figure 5435 illustrates a well-reduced A2 trochanteric fracture fixed with a cephalomedullary nail. On the AP view, the Garden alignment index is 175 degrees, and on the lateral view, the screw is positioned 5 millimeters from the joint line. This is considered an ideal fixation. Postoperative care. Postoperative management is just as important as the surgical steps. Patients should be mobilized early, ideally with full weight bearing, unless contraindicated. Early rehabilitation reduces complications such as pneumonia, thromboembolism, and deconditioning, which are especially dangerous in elderly patients. Hemoglobin should be closely monitored as blood loss in these surgeries may require transfusion. In patients with cardiovascular disease, transfusion thresholds may need to be adapted to maintain stability. Early discharge planning is critical since many patients will require assistance at home or in rehabilitation facilities. Complications. Trochanteric fractures treated with cephalomedullary nails are prone to several complications, and these are frequently tested in exams. Cutout and varus collapse. This is the most common complication, where the lag screw migrates superiorly and exits the femoral head due to poor reduction or malposition. Figure 5436 shows central penetration of a lag screw, known as the cut-in phenomenon. Revision surgery is often required. Refracture around the implant. Fractures may occur at the distal tip of the nail, particularly with short nails because of stress concentration. Figure 5437 illustrates a fracture at the distal tip of a cephalomedullary nail. Implant breakage. Nail breakage is rare with modern designs, but may occur with delayed union or non-union. Figure 5438 shows breakage of a nail secondary to non-union, with failure occurring at the weakest point where the lag screw crosses the nail. Non-union. Reported in 1 to 3% of cases, usually requiring dynamization or revision surgery. Malunion. Varus malunion and femoral medialization may lead to limb shortening and poor functional outcomes. Avascular necrosis of the femoral head. Rare, but possible if the vascular supply is compromised. Figure 5439 demonstrates avascular necrosis following trochanteric fracture fixation, where the initial screw placement may have damaged the vascular supply. Outcomes and future directions. Despite complications, cephalomedullary nails remain the gold standard for unstable A2 and A3 trochanteric fractures, while sliding hip screws are still acceptable for simple A1 fractures. Mortality after these fractures remains high, about 8 to 10% at 30 days and up to 38% at 1 year, mostly due to comorbidities rather than the fracture itself. Future directions involve improvements in implant design, better assessment of bone mineral density in elderly patients, and early multidisciplinary rehabilitation. The goal is not only fracture healing, but also prevention of secondary fractures, which are common in this frail population.